Today. Thank you very much for joining us. My name is Ruth Ackerman. I am a staff member of the Ontario Pharmacists Association. I am a pharmacist as well. And I will just do a little housekeeping. Obviously, it's what you guys know the drill, questions in the Q&A, and we will answer them as we go or towards the end. We don't have any slides for you today, but we do have two amazing people to talk to you, people with lots of knowledge. I just want to say thank you very much to Vanessa Mooney and the rest of the staff at the Nurse Practitioners Association of Ontario. Great bunch of people, and we're really excited to do this and bring some information to you. So if you have any problems, put something in the chat and I'll be able to see it. So we'll help you with any technical issues. So Vanessa's not going to say anything, but I really welcome Vanessa to the webinar. She's going to go dark like I am going to go dark soon, and we'll leave it up to our two speakers to speak. So I'm going to introduce Jen Belcher, who is a pharmacist, and she's the Vice President of Strategic Partnerships and Member Relations at the Ontario Pharmacists Association. She is an actively practicing pharmacist. I don't know where she gets the time in both community and hospital pharmacy. So she's brilliant. And she is going to be speaking to you about some about Paxlovid or COVID-19 therapeutic support line. In the chat, I have put the phone number. Jen will explain what it's all about. And then we'll be, so I'm just going to close off now, and Jen, take it away.
Thanks so much, Ruth. I think anytime you introduce me, I leave feeling a little bit better about myself, and it gives me that little ego boost. But I have the distinct pleasure by today being joined by Dr. Daniel Rashkovsky, the Associate Chief Medical Officer of Health, who is, if we're going to be being complimentary about people's knowledge and expertise, probably the main reason that you have all signed on to this webinar, and I'm completely okay with that. One of the, real reasons that we started having these conversations was with the Nurse Practitioners Association of Ontario, was to look at opportunities for this type of collaborative education where we can share different perspectives and look at enhancing that collaboration, communication, and opportunity to create access for our patients in the community, knowing, of course, just the constraints that the healthcare system is currently under and the importance of collaborative team-based care. So we really do want this to be an interactive session. Please don't hesitate to throw your questions into that Q&A function throughout the session, because as Ruth mentioned, we don't have slides. So we would love to address some of those pressing questions. Fortunately or unfortunately, there are still some really important topics in infectious disease and the public health sphere that we're looking to give some updates and provide some context around, new and emerging issues, changes to existing programs and so forth, just to help with that system navigation and keep everyone current. Ruth had mentioned that COVID-19 therapeutic support service and the number being in the chat. I will also throw the website in there that contains a lot of really fantastic self-serve resources for anyone who does have questions around the management of patients with COVID-19 or in questions around the current recommendations for the COVID-19 vaccination effort, or the management of patients with post-COVID condition or long COVID. So this service is provided by the Ontario Pharmacists Association for any practicing healthcare provider within the province of Ontario who's seeking support, whether it be looking for assistance with management of drug-drug interactions with oral COVID-19 therapeutics, questions around how to facilitate access for your patients to therapeutics, current vaccine recommendations, and a variety of the different emerging questions that we typically get. We'll cover towards the end in some of our hotline frequently asked questions, because they may be some of those questions that you would be thinking of asking. So without further ado, because we're not just going to cover respiratory illness and COVID-19, there are some other topics. I will pass things over to Dan to provide just sort of a general top line status update on some of the key public health concerns right now.
Great. Thanks so much, Jen. Hopefully everyone can hear me okay. And I'm going to plug your OPA service as well, because just everything we've heard back from clinicians who are using is just that it's super, super helpful in anything prescribing COVID related. It's been wonderful, and we're really, really glad that it's something you guys are providing. I'm going to give a bit of a smorgasbord of public health stuff today, if that's okay for people. If anyone's really bored, you can just skip me along to the next one. But I'll start off with a bit of just kind of a respiratory update, because I know that's still kind of the main reason a lot of us are tuning in today. So first off, obviously our respiratory season has ended in Ontario. We're into April. It's finally nice outside, not particularly today, at least where I am in Toronto, but yesterday was beautiful. So whether it's COVID or flu or RSV, everything has been on the downslope since at least January. That's incidence of new cases, outbreaks, hospitalizations, even our wastewater signal has been trending down since that time, which is great. A few things I think of note about our COVID, RSV, and flu seasons this year were, number one, this was a much more normal RSV season than the previous season. It followed kind of the normal timelines, patterns, the number of individuals that we would see, so it was much better. Flu was also a bit more of a standard flu season, which was kind of nice in terms of timing, whereas it came a little bit earlier last year. COVID was a bit different in that it started early, and what happened is we kind of got a bump of several variants of concern, one after the other, through EG5, HV1, JN1, that kind of kept things fairly steady and increasing throughout most of the fall until we stopped getting new variants and it clipped off, and so we've been on downgrades since then. So COVID remains not a fully seasonal respiratory illness at this time. It's still driven by kind of global trends and new variants. So we continue to watch very closely, but again, doing really well right now. So in terms of COVID, Paxlovid prescribing, Remdesivir prescribing has been following the incidence and decreasing significantly since January as well, which is nice to see that we're following so closely. Just a quick reminder, so the availability right now is still fully publicly funded for anybody who is deemed high risk. That's over 60, immunocompromised, high-risk medical conditions, under-vaccinated, any of those groups. Ontario Health is doing an update of that guidance that we expect to be published in the next month or so. Probably many of you have seen the latest New England Journal of Medicine study that came out saying that Paxlovid doesn't appear to reduce duration of symptoms for people who are fully vaccinated and are not otherwise ill with the conditions. So that and several other studies and new research has been taken into account. And so we'll likely see a bit of a tighter guidance in terms of who is best suited to receive Paxlovid and Remdesivir. And that'll be coming shortly. Currently, we do still have Paxlovid supply available in the province. Only the renal packs are here now. So for those of you who are dosing it, just be aware that the renal packs are what we have. But you can combine to make the appropriate dose, of course. And that will be available until end of May when the product that we have expires. There will absolutely be information coming out from the Ministry of Health well before product expiry in early to mid-May to let people know what's going to happen going forward in terms of eligible population, reimbursement criteria, supply, all that stuff. Still kind of working through the process now to be clarified, so unfortunately can't share anything about that yet today. Remdesivir also remains available. It has been, really primarily used by our HCCSS home and community care services and a little bit of long-term care. But if you are seeing patients who have home community care services would be eligible, absolutely consider Remdesivir for them if it's more appropriate than Paxlovid. The last thing COVID Paxlovid related I'll say before we move on, and happy to pause for questions anytime, Jen, if you think that makes sense, is about the CANTRI COVID study. They are still recruiting, so particularly of patients who are maybe borderline in terms of eligibility based on the current guidelines recommendations, you consider sending them to enroll in the CANTRI COVID study. We can put the link in the chat afterwards and share. But they'll be randomizing them to receive COVID medications, and it's been a really, really valuable in terms of getting a better understanding of how well are these really working, particularly now in the new era with the multiple vaccines and previous infections that most people have had. Okay, that's the COVID blip. Oh, except I missed the spring vaccine campaign. I knew there was going to be something. The spring COVID vaccine campaign has officially started as of the beginning of April. So consistent with NACI, anybody who is highest risk is eligible and should be coming forward to receive another dose. This is primarily individuals over 65, individuals living in long-term care homes, retirement homes, or other congregate settings, immunocompromised individuals, and Indigenous individuals from 55 and older in their household. Other individuals who are still trying to complete their initial series or for whatever other reason may be high risk can still be considered. And as long as they've had that discussion with their healthcare provider about appropriateness of vaccination for them, they can still receive it. They don't need to know, nothing like that, but they should just be included if it makes sense for that particular population. For flu, I'll keep going until Jen stops me. So flu, a couple of things of note just to raise. Number one, so our flu season is over. Pharmacists does still have a small supply of flu vaccine available. Particularly of note, there's some information coming out about highly pathogenic avian influenza, which I'll talk a little bit more about later. Maybe I should now. But specifically for workers in the industry where they might be exposed to avian influenza, if they haven't gotten their flu vaccine, still makes sense to do it now. Outside of those particular individuals, not really a need for others to be rushing for flu vaccine at this point in the season. It's totally done, but it is available for that particular group. The other thing is for the 24-25 season, many probably heard, so we have declared that one of the flu strains that we were previously covering is extinct. So this is the B Yamagata strain. It has not been seen a number of years. It was officially declared extinct, not seen. So we're no longer going to be needing to have a quadrivalent flu vaccine to protect against all four, the 2A and the 2B strains. So this upcoming season, again, we don't know exactly what products will be available yet, but they will all be trivalent products. We won't be looking for quadrivalent anymore because we simply aren't seeing that strain in existence, and there's no need to continue to provide protection against it. Lastly, on respiratory for RSV, so this past season was kind of the first season of our RSV vaccination program for older adults, using the Arexvy product that was available. This upcoming season, we expect expansion of that population to a slightly broader group, at least including, all retirement home residents plus the initial group. It's still not completely clear, and we're waiting for advice from NACI, which should be coming this summer, about is this an every year vaccine or not? A lot of the evidence that came out around Arexvy was it probably lasts 2 years or potentially more. So it may not be something that needs to be given every single season to everyone who's high risk. More to come from NACI on that one, but we will continue to have a high risk vaccine program for older adults for RSV this upcoming year. The last one is around our infant high risk program. So many of you might be familiar with Synagis, as the program we've had for many, many years. The newer product, Beyfortus or nirsevimab, was approved last year. It wasn't available in Canada last year due to supply. We are expecting that it will be available this year. And so details still to come on what the scale and size of that program is going to be, but it's very likely we'll have that product used in the high-risk infant program. That's the respiratory season stuff, Jen. If you want to, I don't know if you want to pause if there's questions, or I can roll on to the rest of my smorgasbord.
Sure. Maybe let's pause on the respiratory topics, just because I know sort of a big bucket of why people may have signed on today. If anyone has any questions, you can throw them into the Q&A. I think, on the flu topic, I believe there's been communication from some health units around the return of the 23-24 season's product with both, unopened and open vials. I know in my health unit that's occurring, I believe the end of this month. And so, with that avian influenza component to it, there would be some level of urgency in having those individuals look to access product prior to the return of stock overall, when we think of it in that context, given that we're mid-April. So just some perhaps logistical considerations, whereby if you have high-risk patients, there may be some urgency to ensure that they're receiving that communication prior to that stock returning. On the RSV topic as well, too, I know, we'll be doing some more education as an association quite extensively on this topic over the coming weeks and months. And so if you are an OPA member, you'll be receiving communications around that, but it will be education that is open and freely available to both non-members and members. So of course, anyone on this line who's not a pharmacist or not a member would be able to access that. And we're looking forward to doing some of that deeper dive exploration around the range of RSV products that will be available in the coming year, how to look at product selection based off of the demographic and indication, the role of maternal immunization in protecting infants, as well as the high-risk infant product, and really, helping practitioners to try and synthesize what is a very newly emerging field of vaccine science and infectious disease prevention, because as we all know, with multiple product launches over a short period of time, it can be challenging to integrate that knowledge and have the resources at your fingertips. So we look forward to being able to deliver that in the coming months. So keep an eye out in the OPA communications for that. And we're getting some good questions here. So what is the status and future plans for providing COVID rapid tests to Ontarians eligible for therapeutics?
Yeah, great question. Those plans will be announced in May along with the therapeutics. So it's still working through in terms of exactly what will happen. As of right now, rapid antigen tests are still widely available. If you need them, you can order them through the supply portal that I'm sure everybody is already familiar with. And we still have plenty that is in the province right now. What it will look like next season is to come again around early to mid-May, along with lines of the rest of therapeutics.
We also have one around the maternal immunization product, Abrysvo, if there's any early indication as to whether or not there will be public funding available in Ontario for pregnant patients in that final trimester for immunization.
Yeah, that's a great question. I think likely, yes, there will be some available, is what we'll see. Again, it's not clear. We're still waiting for the final NACI statement, but all the indications and the evidence so far looks like nirsevimab or a monoclonal product that we have is probably better for protection for those young infants than the maternal RSV vaccine. And again, the primary use of that vaccine, of course, is to protect the infants. The protection for the adult mothers is pretty minimal from what we're seeing in the studies. So if we have a very broad program that's covering infants with one of the monoclonal products, that looks like the preference in terms of it. But will we have some available for parents who aren't comfortable, kids who can't have nirsevimab, all those sorts of hosts of reasons? Likely, yes, there'll be some available for that much smaller population.
And just from the pharmacy context, what you will typically see then is if it's not a universal publicly funded program, pharmacy will have that role in both the dispensing and potentially immunizing adults who present with prescriptions for that product. Of course, if we start to see RSV vaccines become Schedule II, then whether or not they are a prescription only product, that access through pharmacies starts to expand practically because a prescription is no longer required in order for someone to self-select that product, providing that the pharmacist determines that it's indicated and in the best interest to provide that individual with that vaccine. But we do have some challenges due to our scope of practice, not being able to prescribe. Typically, there may be challenges for individuals using their private drug coverage in order to fund those products or services. Really is an insurance program by program decision as to whether or not pharmacists are deemed to be authorized prescribers and whether that claim would be funded for those individuals. So, from an access standpoint, I think it's nice for everyone to sort of wrap their heads around why perhaps pharmacies may be referring back to prescribers for prescriptions where products may be technically, over the counter available or so forth. But ultimately as well, when we think about the immunizing of children, perhaps, we still have the limitations on our scope of practice that for anything apart from COVID and flu, the age in which we can begin to immunize is 5 years old and up. Flu is from 2 and up, and COVID is the indicated age in accordance with the product monograph. So we still haven't harmonized that scope of practice for pharmacists. So there may still be access challenges for individuals with younger children with those products. We think, we'll talk, I'm sure, a little bit about meningococcal B and status there, but of course with the immunization of younger children, that may not be able to happen in a pharmacy without something like a medical directive or direct order in place if that child is under 5 years of age. And I see just a question around receiving the updates, and perhaps there's an opportunity if Claudia, if you're a nurse practitioner rather than a pharmacist, for us to share that information with your association, go through those channels. We also do publish a lot of our education. I'm just going to pop it in the chat here. We have a lot of programs that are available to our non-members at absolutely no charge, and may be pertinent to your practice. Many of them are more disease state or therapeutic area provided, and happy to share that information if there's that appetite across the associations, and at the same time as well share resources that you think would be beneficial for pharmacists to know with our member base. And this is a really nice opportunity to start that sort of collaborative approach to ensuring that we're all tied in together with the knowledge that we obtained. So I'm very happy to collaborate on that, and look to continue that. So perhaps if there's no more questions on the respiratory, maybe we'll move into some of the other hot topics.
Sure. Yeah. Happy happy to jump on. So I guess I'll quickly go into the highly pathogenic avian influenza since I mentioned it. So for those who aren't aware, so highly pathogenic avian influenza, bird flu, it's been around for a long time, primarily in birds. Probably guessed that from the name. We have had cases of avian influenza where people who were in very close proximity to birds have gotten it. And so it can be making some people very, very ill. It tends to present slightly differently than classic flu. Conjunctivitis is a really, really common one for avian influenza that we don't often see with the kind of the standard seasonal flu. But the big note was that in the US, 8 states to date that I'm aware of have reported identifying avian influenza in their dairy cattle. So this is a big jump moving from birds now to mammals. Theoretically, this is one step closer to humans. We're closer to cows than birds. And there's been at least one case identified in a human individual in the US who was a cattle farmer, which is only the second case ever of avian influenza in the US, which most of the cases have been globally in other jurisdictions. We haven't identified any human or animal cases in Canada so far, but obviously those in the dairy industry are watching very closely to see if anything does come up. The avian influenza has been found in fairly high quantities in the milk, is one important thing. So pasteurization, really, really important for any dairy products that are coming from these places. And then again, the note that I mentioned, so specifically those working in dairy farms, poultry farms, that sort of area, if they haven't had the seasonal flu vaccine, still available at the pharmacy, please, encourage people to go get it. At this time, we don't know exactly how much protection it will provide, but we do know it provides additional protection against avian influenza as well. So that's the quick update on avian influenza. I will just keep rolling. I think probably measles is a good one to go to next. Lots in the news about measles lately. So Canada, I'll just say, is still doing very, very well for measles. So in Ontario, we've had 13 cases identified to date. 12 of those were directly travel related. So individuals who contracted measles outside of Canada and then upon arrival developed symptoms or had symptoms, sometimes on the plane, unfortunately, and were identified in Canada, which is historically what we've seen for the vast majority of time is that, again, people are catching measles elsewhere and coming here. Measles has been eliminated in Canada since, I'm going to forget the exact year, I want to say 1998. We haven't had domestic transmission of measles. One of the cases in Ontario, there was no source identified, but when we looked specifically at the type of measles and the strain, it was a strain that is currently circulating in Eastern Europe and the Middle East. So even though this individual didn't travel, they very clearly were in contact with someone who had just traveled from one of those locations. So really, we're all travel-associated cases in Ontario. Quebec had a fairly large outbreak at one of the hospitals in Montreal, Saint-Justin, where an individual, again, acquired outside of Canada, essentially transmitted to a large number of individuals who were either patients waiting in the emergency department or healthcare workers there. And so they have the most cases in Canada at this point. They're in the 30s now. I can't remember exactly when. But again, outside of that specific large episode, they haven't really seen domestic transmission either. I think the concern we all had was post-COVID, we really don't know what the coverage rates are like across Canada. It's a tough one. Some provinces do better than others. Ontario, I think we all know we don't have an immunization registry or repository. We actually have a very hard time tracking doses. Some provinces do a little bit better, but the concern was that, particularly for the younger age kids who haven't had their first or second dose, so we don't know, is spread there going to occur? Again, thankfully we haven't seen it yet, but I think the main thing is we just all want to be aware and have on our radar, if you're seeing a patient, particularly someone recent travel with unknown immunization history or without having had measles immunization, please, pretty please think of it very early on. when you're triaging and doing that assessment, and try to remove them away from the rest of the patient population as soon as you can, or again, direct them to emergency department somewhere where they can put those measures in place. And absolutely, if you're sending them somewhere else, please call that place in advance and say, this is a suspect measles case. Get ready, they're coming, take them aside, sort of thing. A final reminder, any suspect or confirmed case of measles that you do see should be reported to your local public health unit as well. So measles vaccine, I'll just talk about quickly. So everyone in Ontario, I think we all know the routine childhood schedule. You get your 1 year, you get another one at 4 to 6. Everyone in Ontario over the age of 18 is eligible for at least 1 dose, regardless of birth, if they have never had one before. The high-risk program also provides a second dose for particular individuals, including healthcare workers, which is everybody on this phone call right now, but also people who are traveling to areas where measles is transmitting, which is almost everywhere in the globe, or if they have other particular healthcare conditions, reasons based on the healthcare provider's judgment. So again, the priority is still kids, to be clear, and kids particularly under the age of 5 who haven't been fully immunized. That's where we want the focus to be on, but if you are seeing patients in those other populations, it can be considered.
And as a point of clarification, this is one of the questions in the Q&A is with the Pharmacist Vaccine Administration Authority, MMR vaccine is not one of the vaccines that we are authorized through independent scope to administer, nor do we have access to the publicly funded stock in pharmacy for really any of the programs apart from influenza and COVID-19. And so, therefore, any individual who would be accessing immunization services from a pharmacy, it would be on the privately funded side, whether it be through their own cash paying mechanism or their drug plan. And so from a direct involvement standpoint, community pharmacy really won't be a point of access for MMR vaccine in any way, shape, or form in the very near future. We are restricted to the list of vaccines that are listed in Schedule 3 of the regulations of the Pharmacy Act. If anyone's really interested, I can pop it into the chat. But ultimately, we do still have limitations on our scope of practice, both in terms of the range of vaccines that can be administered by a pharmacy professional, be it a pharmacist or a pharmacy technician on the injection itself, no prescriptive authority, and no access to the publicly funded supply. We are actively advocating to change that. I think, the role of pharmacists as immunizers has been well documented in both influenza, COVID-19, and in other jurisdictions where pharmacists are part of that routine immunization program. Of course, with concerns around the immunization of young children, ensuring that parents are still attending those well baby visits with a practitioner that provides that level of care. From our profession standpoint, it is by no means looking to interfere with that type of care, but more to provide those additional points of access. So for the pharmacists on the line, if you are concerned or you have patients that are concerned about measles, the best points of access to recommend at this point in time would be for them to see their primary care provider or public health for one of their measles or routine immunization clinic services in order to be able to access that. We do have actually another question. It is related back to respiratory, but more on the pneumococcal side with the PCV20, knowing, of course, that the Ontario Immunization Advisory Committee had made the recommendation around the value of looking at a 1-dose approach to pneumococcal immunization. And, do we have any sort of predictions around when we might be able to expect updated Ontario guidance for the publicly funded program on the pneumococcal immunization product selection?
Yeah, really good question. So as a quick reminder for everybody, NACI's come out with their statements already for both pediatric and older adults for pneumococcal vaccine. Older adults, they said pretty clearly PCV20 to be the product of choice. For pediatric, they said PCV20 for high-risk infants, but PCV15 or 20 could be considered for low-risk kind of routine immunization. So, Ontario is going to be moving to follow the recommendations from NACI. I think we're probably about a month or 2 out from an announcement officially on what that program is going to look like and which products will be available. The procurement is still ongoing to see exactly what's going to happen. Clearly, for kind of the high-risk kids and for the older adults, PCV20 will be here. That'll be the one we have. That's what NACI is saying. It's really for the low-risk kids what's going to happen in the procurement state. So more to come on that one. But yes, we'll have the 20 for the older adults at least, and that's pretty clear.
Right, any additional questions on our measles or pneumococcal before we maybe move on to the next on the Rolodex, I guess?
Yeah.
I think we're good. We
Okay.
can carry forward.
Okay, I will keep going. I wanted to give a quick update on meningitis B. So probably many people are aware of the increase in cases that we're seeing in Eastern Ontario, particularly around Kingston area, where there've been a number of high-profile incidents of hospitalized post-secondary students, particularly, which is a population where we commonly see Men B cropping up. Everybody has been okay, and no deaths, anything like that has occurred, but it's been a little bit above what we see as kind of the background rate. The health units in that region went forward with like fairly broad campaigns for anybody who has potentially contacts with individuals. But at this time, the quick reminders, so meningitis B program is not part of the routine publicly funded immunization schedule. It's under the high risk for people with certain medical conditions, but it's not really a routine infant vaccine that we have at this point in time in Ontario. Some jurisdictions in Canada are starting to move towards that direction, or some jurisdictions have moved toward providing that for that post-secondary age student. So Nova Scotia, I believe, was the first, and PI now as well, are both providing it for individuals in post-secondary education. I think that this is something that's kind of ongoing discussion in Ontario is what's the meningitis B program going to look like? Particularly, we know that there's a pentavalent vaccine coming soon. So we all, I think, are familiar with the MenACYW. They're going to add a B into that one in the very near future, which would make things a lot easier. And I think we can safely say that would be something that's picked. In the meantime, adding MenB, whether it's in infancy or post-secondary, is kind of an ongoing discussion. So certainly it's available for that high-risk population. It's in the immunization schedule. We can put that in the chat afterwards for sure if you don't know how to quickly access it. But outside of that, it's really outbreak response or case response is the primary use of MenB vaccine. It is, of course, available privately for anybody who has coverage or wants to pay out of pocket. And often that is still the recommendation even for people attending post-secondary institutions to get those, even if it's just through the private coverage they have available. Particularly in, definitely in the Kingston area, that's been the recommendation that's come out. So more to come probably in the fairly near future, about hopefully before September and people go back to school, about what the recommendations are going to be.
And just a note for pharmacists on the line, with the scheduling of meningococcal vaccines, they were all Schedule 2 based off of NAPWRA scheduling. So they can be purchased without a prescription. So you can provide access for those perhaps that don't have a prescriber through that mechanism. But once again, clarity if they have a private drug plan as to whether or not a prescription written by yourself could be billed either online or the patient could submit for reimbursement, because whether you were looking at a population that's using the 2 or the 3 dose product, which are all currently quite well available. And I know there were some initial, at least in my region, which is the Kingston area, some shortage concerns due to some short-term issues with transportation of the vaccine. I believe there is a healthy supply available in the community for anyone who is looking to be immunized, and supply is not a concern, but that ultimately from a pharmacy access standpoint, if a patient doesn't have a prescriber, that does not require a prescription in order to be provided to the patient, but there may be rationales for seeking one out from a funding standpoint. So ultimately it's within our scope to administer 5 and up, of course. So children under 5 would need to be referred out to a different provider or immunized under a medical directive or direct order on a prescription itself. Any questions on meningococcal B? Okay, let's keep on carrying forward.
I've got 2 more big topics, Jen, and then they'll be done talking. So quickly, I did want to give a little bit of an update on Mpox. Probably, especially in the Toronto area, people have been more aware because that's where the majority of cases have been in Ontario. But there was a spike in Mpox cases earlier this year. So between January and February, there were 28 cases, I want to say, that were reported, compared to 33 cases in all of last year. So the initial outbreak was in 2022. We had quite a few cases in Ontario, in Canada, globally, and it certainly has slowed significantly since then. But it is simmering along, and we keep seeing things pop up occasionally. Again, Toronto is definitely the epicenter in Ontario, what we're seeing is that most of the patients are still unvaccinated. There remains a vaccine that works pretty well from what we've seen to protect individuals from Mpox. It is still publicly available. It's primarily available through local public health units for those who are potentially eligible, or some sexual health clinics in the community, depending on the particular health unit location. The reason for this is that, quite frankly, the supply is still coming from the federal stockpile. It's not something that's being purchased separately and incorporated quite yet in the immunization program. NACI will be coming out with additional guidance on that also in the near future. They're having a busy year this year from what I've described already. But once that comes out, we might expect things to move to a more standard public program. But for now, it is, again, very focused through local public health. As a quick reminder, it's anybody who is gay, bisexual, men who have sex with men, who have any risk factors like recent STI, multiple partners, anonymous sex, using hookup apps, those sort of things, and anyone engaging in sex work are all eligible to receive 2 doses. Strongly recommend they get both doses. The protection is going to be much higher with that second dose. And again, the vast majority of the cases we're seeing are totally unvaccinated. So if you do have any patients or anybody's asking about it, again, it remains available primarily through local public health. If people have questions, they should be calling their health unit to access it. And that's a vaccine that loves to see the uptake increase.
Any questions on Mpox? I think we're good to keep going.
Perfect. Okay. The last one I want to talk about, Jen, was about ticks, just because we're starting to get to the season. And obviously, the pharmacists are it's within scope of practice now for those tick bite assessments. Lyme disease being the primary one we've all been concerned about. And Health Quality Ontario has a wonderful guidance document going through what to look out for, treatment algorithms. It's really quite thorough in terms of ticks. I think they just updated, I want to say last year, and I think there's another version even coming out this year that should be updated soon. So it's really a very good document. So for any questions anybody has about how to identify, assess, treat, test for tick bites, that's a great place to go for Lyme specifically. I wanted to just mention that there's Lyme, which has always been reportable. There are now 3 additional tick-related illnesses that are reportable to local public health: anaplasmosis, babesiosis, and Powassan disease. As of last year, are all reportable to public health as well. The testing, clinical presentation, all those pieces are slightly different than what we see, obviously, for Lyme disease. And so I strongly encourage people, if you aren't familiar with them, go take a look. These are ones we normally see primarily in Northern Ontario, not quite as much in the South where Lyme is more predominant. But absolutely something that we do see cases of probably every year in Ontario. Certainly last year, I think we saw a couple anaplasmosis and babesiosis cases. So just to go and increase awareness around those one, Public Health Ontario has very clear guidance on what the testing should be for those situations and anything you're looking out for. So if you aren't familiar with those other 3, please take a look, just peruse, make sure you're a little familiar with what they look like, how to do the testing in particular, and incorporate that into kind of your Lyme assessment algorithms overall.
Yeah, that would be really important for pharmacists on, the follow-up monitoring to our prescribing of the post-exposure prophylaxis, and ensuring that patients are aware of when and where to seek care if their symptoms aren't resolving or occur. I did throw into the chat the public health algorithm for assessment and prescribing for antibiotic prophylaxis for Lyme. That is also referenced on our college's website, and just from an interdisciplinary standpoint, one of the algorithms that pharmacists would be following in the minor ailments program, whereby we're assessing for and prescribing the antibiotics for post-exposure prophylaxis. With that as well too, there had been some more restrictive limitations on the number of times that someone could access a pharmacist throughout the course of a 365-day period for Lyme assessment services. That was expanded somewhat, acknowledging that those who are high risk of tick bites often may accumulate more exposures than were previously allowed for, and were funded through the minor ailments program in pharmacies. So that has been expanded somewhat, but there may be instances if someone is unfortunate enough to be receiving a very high number of tick bites within a 365-day period, where they may still need referral to an alternate level of care, not because of necessarily concerns around that specific instance, but because there is not public funding for an unlimited number of assessments over the course of that period. So we do have some of those resources, and Ruth threw another one into the chat for us with the Health Quality Ontario algorithm. From the antibiotic prescribing standpoint, pharmacists do follow public health algorithms for both of the conditions in which we give antibiotics to patients for both urinary tract infections, uncomplicated, of course, and the Lyme post-exposure prophylaxis. But there's some really great resources, even just embedded within these algorithms, with the surveillance opportunity for patients to submit pictures of ticks if they so desire, if they have the opportunity to do so at eTick and so forth. Any questions on vector-borne disease that way, or the tick-borne illness? I think it's really important for pharmacists to be aware of those additional reportable diseases, and in that routine monitoring after post-exposure prescribing, that it's not just sort of an acute one and done. That ultimately there are some of these other vector-borne diseases that need to be considered in addition to Lyme, and if you what our role is in that ongoing patient management and monitoring, now that we are a primary point of contact for some of those initial post-exposure care events. All right. Any questions? Do we expect an early year for ticks due to the mild weather?
Yeah, probably. Right, it's really just dependent on when people are getting outside and getting exposed more often, and ticks start to get more active when the weather comes up. So again, like season's probably starting now.
I can tell you from our prescribing data that we have through a software support tool that we have for pharmacists called MapFlow, that we're starting to see that uptick in tick assessments being done throughout the platform. So I'm in Eastern Ontario, where there are plenty of them, and fortunately I haven't had to pull them off of anybody just yet, but I've seen a couple crawling around. So it has been an earlier year. I don't know that we had enough of a winter to really, we had an extended season as well too into the fall, I believe. So definitely something that should be on people's minds, especially as we're taking advantage of some of this nicer weather. Not in Toronto today, but overall.
Yeah, we're seeing the length of the season extended every year, and we continue to see, just specifically for Lyme, the range of those ticks creep further and further north every year. So just keeping it in mind, even if you're north of the line last year, get ready for this year.
Yeah, I think it's also had some of a bit of an impact on prescribing in the pharmacist space on things like allergic rhinitis and conjunctivitis, and sort of extending those seasons with the changes in climate patterns, pollens, the amount of pollen, the wildfires, of course, that we experienced last year, and the impact of smoke on respiratory health, and some of those respiratory conditions, including seasonal allergies. I think that sort of gives the run of everything that we were looking to cover. I kind of added in some of like the scope or access considerations from that practical standpoint of, what our shared patients might expect across more the community pharmacy dynamic, of course, in various different practice settings. For example, in hospital, pharmacists often practice in a different way, so may not be providing that same range of services, or may be constrained by organizational policies or legislation that pertains specifically, for example, to hospitals. But excellent. I see here there's has there been a spike in tick-borne illness related to the mild winter? Have we seen not just in terms of the bites and the need for post-exposure prophylaxis, but actual reportable disease?
Yeah, I mean, we still didn't see much over the winter. Like, even the winter was mild, it's still cold enough. The ticks aren't really moving around the same way, and people aren't getting exposed to them. Right, and like people are dressed up in their winter coats and their snow pants and everything if they're going to the forest, and even in a more mild winter. So we just don't see the exposure in the same way. No, we didn't see a spike over the winter season yet. It's more starting earlier, ending later sort of stuff that we see.
Mm-hmm. And then I think one of the things that we thought we could just cover off briefly were some of the frequently asked questions that we have been getting on the COVID-19 therapeutic support line, sort of rounding back to the respiratory domain. Just because, we figure that if they tend to be our most frequently asked questions, maybe they're in the back of your mind somewhere. And so I do have a bit of a list here that we can speak to, but I would say that probably one of the main questions that we get asked is around people's ability to access oral therapeutics in a more not necessarily preventative, but a precautionary way, because they expect to travel out of country and are not sure what their access from a timely standpoint would be to receive therapeutics, and are they able to be accessed through the current program in a sort of preparatory way in case of infection, rather than in response to a confirmed COVID-19 infection?
Yeah, it's a great question. We get it all the time. So with the current program, it still requires a positive test for dispensation for Paxlovid or for remdesivir, but you got to get an IV infusion for that one, so it's harder to do it. So it's not going to be changing until we get kind of the update to what's the new program, what's the new reimbursement model, what's the new eligibility going to look like in May. So for now, it's still you need that positive test to have treatment.
Yeah, and I think what we saw was that there were some prescribers that were issuing proactive prescriptions, and that is not something that pharmacists are able to do. So our scope of practice specifically limits prescribing to in response to positive cases. That scope of practice, because it's not specific to Paxlovid for other prescribers, is not necessarily that constrained. But in order for the pharmacy to dispense a course of therapy, and this is where like the practical access whereby a prescription could remain on file in case an eligible patient were to present as COVID-19 positive, but it cannot be dispensed in the product provided proactively. So a little bit of a differentiation there that I know caused some question around why there was a slight difference in the policy based off of the provider with which you're accessing it from. But regardless of who's prescribing it and whether it's proactive or reactive, the actual provision of product does require a positive test in order for that to be provided to the patient. So practically, yes, you have to have a positive test, and it cannot be provided just in case or in case of travel. Another one of our probably most frequently asked questions is that a patient has a repeat COVID-19 infection, and are they able to be to receive therapeutics again? Are they able, if they've received oral in the past, does it have to be oral, or could it be oral? Should it be IV? Should you look at a different agent? And how to manage sort of those repeat COVID infections in our highest risk population?
Yeah, I think the first thing though is just really to defining if it's repeat versus rebound symptoms is the number one thing to clarify. So rebound symptoms we know are common. I think we initially identified it after treatment of Paxlovid, although some of the latest evidence is suggesting that it's something that happens just with COVID generally. We were just looking specifically at Paxlovid, and that rebound symptoms are very, very common a couple weeks after even a COVID infection. So, if we're within that very short time period, if it's only been a week, 2 weeks, 3 weeks since last infection, realistically, retreatment is not something that's recommended. We haven't seen any evidence that it should be done. For rebound symptoms specifically, we've shown that, having those rebound symptoms are not indication of more severe disease, first of all. So people don't get hospitalized with those rebound symptoms. And they also aren't transmitting COVID in the same way as they were if they have those rebound symptoms. So it's very different than kind of the acute infectious phase. I guess at some point there's probably a kind of borderline of, well, what if it's been a month, they very clearly recovered, and now they have a new exposure that we identified? Absolutely, in those situations, it may be worthwhile doing different treatment. But for generally, if it's anything closer than, honestly, probably a month for most people, you'd be really questioning whether this is the same illness that we're seeing rebound versus a new infection. Again, there may be scenarios where they got better very fast. It's 2 weeks later, they had a very clear new exposure to their, whatever grandkid or somebody who brought it home, and everyone's positive. It can be considered. But generally speaking, repeat treatment for the same infection, we don't see any improvement or benefits.
Excellent. And maybe just to sort of round it out, and unless there's other questions from the audience, we can probably cap it off. But could you provide perhaps an overview of some of the resources available to practitioners that are managing patients who are experiencing post-COVID condition or long COVID? I know that there's a significant proportion of patients that may be looking to receive assistance with their symptoms and be looking for support from their healthcare providers on this condition.
Yeah, absolutely. So a few things just about what we're seeing now with post-COVID syndrome. So number one is the incidence of new cases of post-COVID syndrome has been decreasing fairly steadily, despite the fact that we're seeing a lot of COVID still transmit in the respiratory season. Kind of the real peak of post-COVID syndrome was during the Delta wave. I think we all remember Delta was by far the most virulent strain of COVID we'd had to deal with. We didn't really have very good vaccination at the time when Delta came, unfortunately, for a lot of people. So that was the peak where, a quarter even of people getting COVID at the time were getting post-COVID symptoms. At this point in time, we've shown as number one, vaccination absolutely is the best way to prevent COVID syndrome. We have very clear data showing that it reduces the risk. So anybody who's not up to date with their vaccine, once a year, twice a year, whatever, depending on the recommendations for the individual, absolutely should be, and it's going to reduce the risk. The other thing we've seen is that, especially if you've had previous COVID infection, which is the vast majority of the population to date, you're also much less likely to be getting post-COVID syndrome. That previous infection ranges by age. So if you're under 50, we've shown 90 to 95%, even if people probably had infection. If you're over 65, it's lower, maybe in the 70% of range, but still most people have had COVID at this point. In terms of post-COVID syndrome treatment, so most people, symptoms resolved after a year, or up to a year, often sooner, but could be up to a year. The most common type of post-COVID we see is still kind of the more vague symptoms like brain fog, low energy sort of thing. Although there certainly are subtypes that are more specific, like cardiac symptoms, respiratory symptoms being a very common one as well, or even like strange autonomic dysfunction. It's still symptom-specific treatment. So if someone has those respiratory symptoms, they should be going for pulmonary function tests. They should potentially be seen by a respirologist, for example. If it's those cognitive symptoms, occupational therapy, going to those sort of supports, that's usually really valuable. It just depends what it is. Within Ontario, so Ontario Health is publishing guidance for primary care providers on management of post-COVID syndrome. That's the first place I'd recommend people go to if you want a little bit more about what to do. And the big chunk of individuals with post-COVID syndrome symptoms can probably be managed within primary care. A lot of it is education about pacing of activities, identifying symptom triggers, working within your limits and thresholds that you have. And that for a lot of people is really helpful. And there's lots of tools that people can do even themselves. Like there's tons of video stuff online that you can use to help manage symptoms. There isn't kind of a single referral pathway to get people to specific post-COVID syndrome care. Again, it's specific to the type of symptoms they're having, and it also varies by region within Ontario. So next step, if you're, for all the NPs on the call, if you're providing care for someone, checking with your OH region in terms of what is the pathway for the next step is the next thing to do. If you think they need to be escalated to someone for more specialty care in terms of management of their symptoms. But again, first thing for everybody is looking at that Ontario Health guidance. It's a really good starting point. Last thing I'll note is that, there's actually Canada-wide guidance that's going to be coming out soon. Kind of some of the initial stuff has been posted. I'll find the link and get it for the chat for everybody, hopefully in the next minute or two. But there's going to be kind of Canadian post-COVID syndrome guidance that covers kind of the breadth and depth of post-COVID syndrome and everything that it's available to manage it. So hopefully that is a reasonable cover of post-COVID for everybody.
Probably more than most of us have gotten in any format. So very helpful.
Well, we have only about 5 minutes left, so if you have any burning questions, I can't imagine anyone would. We've learned so much in the last hour. It's incredible. Daniel, I don't know how you keep up with all this. Everything's changing so quickly, but I want to thank both Jen and Daniel to take time out of their day to talk to you guys about everything public health and respiratory. I want to remind you about the COVID-19 therapeutic support line is available for you, nurse practitioners or pharmacists. What we're finding a lot is that the pharmacists that are calling, mostly pharmacists at this point, are they're kind of finished the prescribing assessment. They just want a little, just to talk to somebody, another pharmacist to say, yes, you've used the right reference. Yes, that sounds reasonable. That sort of thing. And they get information on the ever-changing world of Paxlovid, COVID-19 vaccinations, et cetera, et cetera. So really do appreciate your time, Daniel and Jen. And a big shout out to the Nurse Practitioners Association of Ontario and the collaboration. And Vanessa, you've been great. And we're hoping maybe we can do some more of these. We'd love to work with you, continue to work with you on these sort of things. So I'm going
Yeah, thank you so much. That was an excellent presentation. It covered a lot, a lot of ground.
Yes, there's a lot of stuff happening in public health, isn't there?
There's always stuff happening. Don't invite me to calls. I'll keep talking forever. Usually. So thanks
That's
for cutting me off.
wonderful. Well, I hope everybody has a great afternoon and really appreciate your attendance. We'll take care, everyone. Bye.
Everybody take care.